thought that we will finish today. However, I realized these slides are quite many. So I think we shall finish next Monday. Yes, we are looking at how to take history, how to examine the patient so that you can really inform your oral and dental diagnosis. So last week we looked at several things, and now we are just going to continue from where we stopped. We were looking. So, I think this was the last slide. Let me just go over it quickly again to remind us that's very important. Sometimes the patient who has an oral condition or their chief complaint may be bad breath, bad breath, which of course in medical terms you will call halitosis. And so so halitosis is common, that's a fact. The origin may be in the oral, and if oral, it may be like poor oral hygiene, retention of food particles which have strong smell. It may be cavitations in the teeth. It may be due to coated tongue, usage of artificial dentures. Of course, dentures are almost artificial. It may be due to maybe conditions such as acute necrotizing selective gingivitis, pericoronitis. I told you what pericoronitis is last week. It may be due to abscess. It may be due to the fact that the person is dehydrated, or there may be an ulceration in the oral cavity. And the source of this ulceration can be anything. It can be trauma, it can be an inflammatory response, it may be cancerous. Yeah. You know, the oral mucosa is fond of developing things like squamous cell carcinomas. Yes. So, yes. So basically, there can be dryness in the mouth, xerostomia, bone infections, is due to maybe like dry socket, osteomyelitis, osteonecrosis, and malignancy. Then can be smoker's breath, which has pockets, deep pockets which are retaining food. So there can also be conditions which are outside the oral cavity, not be oral and dental conditions, but outside, things like sinusitis, the ENT of the respiratory tract. Yes, it's likely to have breath, acetones due to maybe diabetes. Good. And halitosis, maybe try and look for things like can be intrinsic or extrinsic. So intrinsic, alkaptonuria, congenital erythropoietic porphyrias, congenital hyperbilirubinemia, amelogenesis imperfecta. I think this you learned with Dr. Quizra, dentogenesis imperfecta, tetracycline staining. Now these days, we don't give tetracycline for children, so tetracycline staining is really becoming rare. Fluorosis, yes, people who live in area where fluorosis in the water, yeah. There are some places level of fluorosis. Enamel hypoplasia, pulpo, the trauma is going to be bleeding, yeah, into the dentine, and it's going to stain the teeth. Root resorption, aging, because enamel is wearing off, so you're likely going to see the stained. Then you are going to look at the past dental history. Past dental history is very important, and you want to look at the frequency of visit to a dentist, dental prophylaxis, their past experience. There's what they call the fear factor. Yes, people fear dental procedures so much. So how was their experience in the past? Yeah, because they could be traumatized, and dealing with such patients will be problematic. Then you want to look at the past therapy. Did they do some periodontal surgeries? Did they do training, and so on and so on? So this is for you to evaluate your patient for their care. Then orthodontic treatment. I think we never taught you anything about orthodontics. We didn't think it is necessary, but yeah, orthodontics is the procedures, it's the science where we try to correct malalignments, yeah, in the teeth. So that's orthodontics. So you want to know about their past orthodontic history. Good. You want to know also about whether they have bridges, yes? Yes. Bridge is a restorative procedure to place missing. Hello, somebody is unmuted. Hello, hello, hello. Please don't unmute because it disrupts me. Yeah? So bridges, I said, devices we use to restore, the restorative devices to replace missing teeth. And so, yeah, you want to find out whether they have fixed bridges, and if so, are they comfortable? Are they stable? Are they fitting well? Yeah. And also you as a physician, you sometimes maybe, let's say you are an anesthesiologist. Some of you are going to become anesthesiologists. Some of you are going to become ENTs. And even maybe you just been maybe a medical officer, yeah? A person maybe has gotten trauma and their bridge could be dislodged, yes? Yeah, because you see, we fixed them, maybe we anchored them on another tooth, so maybe they got dislodged. So you want to find out if they have bridges, yes or no, and so. Any other surgical procedures before in the mouth and extractions, yeah? Was there any oral surgery? Surgery and so on and so on. So you want to find provisos for the determination of caries rate, rate of play, calculus formation. Yeah, you guys now know what calculus is, you know what plaque is. So it's important because that will inform whether this patient is on those conditions. Take care of your patient in a different way. Then you also want know about complications key. Was that and so yes. So yeah, I was saying that if this is their first visit, you really want to find about their fears and you want to find out what is really the problem, which has brought them, and what they really want to be done. Yeah. Then you've got to also look at the medical history. The medical history is very critical in care of the dental condition of your patient, because sometimes they are interrelated. Yeah. So if you are going to want to look at diseases or conditions that contraindicate certain procedures, then diseases that require special precautions or pre-medication prior to dental treatment. For example, a patient with myocardial infarction, hemophiliacs, patients who have been on radiation therapy, and so on and so on. Also, diseases under treatment of a physician, yeah, that will preclude or contraindicate the use of additional medication. For example, anticoagulants, steroid therapy, tranquilizers. Then a history of allergies, yeah, or you see plus, for example, penicillin, local anesthesia, yeah. Yeah, people do react to local anesthesia. Yeah, I've seen that many times. So you don't take it for granted. You need to find out that. And you, of course, you know penicillin is not that one for well. Yeah, so that when you are prescribing for them, maybe they have an infection, then you are going to have to avoid penicillin. Yeah, don't say this is a dental patient, now you forget about your whole medicine. No, you must always remember these things. Diseases that endanger the dentist, patient, or the clinician, e.g. hepatitis, tuberculosis. I think now these days we are talking about COVID-19, we are talking about Ebola, we are talking about all those highly infectious diseases. Yeah. Physiological state of patient. You want to know, is this patient pregnant? Are they aged? You know, elder patients, we must always treat them as they are. Yeah, pregnant mothers, you know that one very well. Then recording of past medical history includes history of past illnesses, healthcare experiences, immunization, non-allergies, and so on and so on. And current treatment includes medications, hospitalizations, you know, have you been hospitalized, have you undergone surgery, and so on and so on. Yeah. In the medical history, you are going to evaluate your patient for cardiovascular diseases, respiratory diseases, gastrointestinal, urinary, endocrine, neurological, hematological, psychiatric, allergic, and the extremities and joints. Yeah. Yes. You know, let me just highlight psychiatric patients. You know, they may not comply very well with any medication you give. So yeah, so you need to find out so that you can plan how best to take care of them. Then you want to look at the family history. Family history. You want to know number of siblings, their age, are they married, they're not married. Yeah. So this will, of course, inform you of the size of the family, the socioeconomic status. Yeah. In dental care, sometimes certain things cost a hell of money. So you want to know whether these guys will be able to afford, yeah? If it's a child, you want to know their psychology and their behavior. Yeah, they may be really overreactive on small things. They may not cooperate and so on. Yeah, so yeah, children from larger families may be more adjustable, cooperative, because they're used to facing challenges before. Then it also helps you to study the peer influence of dietary and oral hygiene practices and the history of any disease running in the family, yeah, like hemophilia. Okay, personally, I've not seen any patient with hemophilia, but you don't take it for granted. Diabetes, yes, this is very common. Even now, there's childhood diabetes, so you got to be really thorough on this. Hypertension in the more elderly, or the older adults, yeah. Then in the newborns, prenatal, natal, and postnatal histories will be taken in case of pediatric patients. Then personal history. Personal history will include things like oral habits, oral hygiene habits, adverse habits, diet history, oral habits, oral hygiene habits, adverse habits, and the diet history. Various habits are many. Dr. Quizra, I think, highlighted these things, the details for you. I'm just reminding you about this. So you need to remember to ask these things, yeah? You need to remember to ask these things. But some of the people, thumb sucking, finger sucking, thrusting, pacifier or dummy sucking, lip biting. Yeah, you may see somebody with the ulcerated lip. The result may be lip biting. Yeah, nail biting, cheek biting, pencil or foreign object sucking. So, yeah. So there may be trauma. It may be different object. And the lip sucking, clenching, yeah, clenching, mouth breathing, bruxism, yeah. I know Dr. Quizra discussed bruxism with you guys. Occupational habits, there are also occupational habits. Then oral hygiene habits, what do we look for? We look for regularity of toothbrushing, frequency and method of brushing. Yeah, how do they brush? Use of fluoridated and non-fluoridated toothpaste. I think, John, we're lucky in Uganda. Most of the toothpaste are fluoridated, except if you buy those ones for pediatrics. Yeah, but the normal ones are usually fluoridated. Type of brush and how often it is. So is it chewing brush or it is this one which is manufactured? Use of other oral hygiene aids. Are they using maybe like chlorhexidine mouthwash or any other mouthwash? Yeah. You want to find out. Then there are adverse habits. Yeah, adverse habits, detrimental habits. You need to record them: alcohol consumption, chewing areca nut and tobacco. Yeah. This, if you have a client who's an Indian, they are good at tobacco chewing with areca nut, and this has a detrimental effect, yeah, on the buccal mucosa. Yeah, it is likely to cause a fibrosis, and you will find that somebody they cannot open their jaw. They have developed fibrosis, so resulting from tobacco chewing. Then dietary habits. It's a detail about what you eat or drink in the order in which it is eaten should be recorded at the time. That's important. What do they usually eat? Yeah, the frequency of eating is important. Therefore, between meal snacks, yes, do they like snacking? Do they take a lot of candies, gums? Yeah. Particularly a person who has caries, dental caries, we want to find out that. Because if they are having many cavitated teeth, then how are you best to help them? Yeah. And then we now come to clinical examination. After taking all that history, you want to start having a look. So you guys are well trained on how to do general clinical exams in pediatrics, in medicine, OBG, and so on and so on. So really not so much different, but only some specific issues to be paid attention to. To perform the examination, you need one, adequate knowledge of the anatomy and physiology of this. Now we're talking about head and neck, which you guys already did very well in year 1 and year 2. So, and even dental anatomy on top of that, you also now know. So now that one I say thick. Well-practiced technique for examination providing minimal discomfort to the patient. Yeah. So yes, you know how to stand. Yeah, which side to stand when you are doing the examinations. Dental yes. Yeah, so and also an understanding of the disease process in the head and the neck region. We have not given you everything, but the basics we have given you to be able to help you navigate your way around. Yeah. So the usual things, the basics, you need to visual inspection, you need to do palpation, you need to do, you need to smell, you need to auscultate, you need to do percussion, you need to aspirate. Those are the normal things you are going to do, depending on what you have seen. Now, visual inspection is standard observation of the anatomical landmarks of the head and neck region to ensure the completeness and accuracy of the examination. It involves evaluating the bilateral completeness of the facial structures. So I think previously when I was teaching you the orofacial fractures, I told you you need to check the right and left side. The right side of the zygoma and the left side of the left zygomatic arch, left side of the mandible. Yeah, things like that to be able to make a better judgment. Then palpation used to determine the size, consistency, temperature, and so to confirm this, you then have to do percussion and auscultation. Olfaction, some odors or smells can be associated with conditions of the patient, such as the smoking habits, poor oral hygiene, sinusitis, metabolic disorders, gastrointestinal disorders. Auscultation is, of course, listening to sounds, is performed by the unaided ear or by the assistance of a stethoscope. This one you already know very well. Is to evaluate the sounds of crepitus or popping, like in case of the temporomandibular joint, and of course when you do blood pressures and so on and so on. Yeah. So yeah. percussion, performed by gentle tapping of the area with fingers or an instrument. So I put there 3 question marks. How will you do percussion of a tooth? Let me see in the chat room. Quickly, how do we do percussion of a carrier's tooth? Carrier's tooth. And the patient has said they've got pain. How do we do that? Waiting. Okay. Place the finger over the root and tap. How do we do that? How do we do that, please, guys? You are 40 in the class. I'm really waiting to see many responses. Nail and tap on the tooth. My God, we don't have nails. My God, do you want to crucify your patient? No, we are not going to use any nail. Any other responses, please. I'm waiting. 1 more minute, I'm waiting. What do we use to percuss those teeth? Okay. Paddy says put a finger on the tooth and percuss with another finger gently. That may not work. Your finger is too soft. That may work in other parts, but not so much on the tooth. Okay, let me give the response. Yes, we usually use the rounded edge of a probe. I think Dr. Quisra might have shown for you how dental probes and dental mirrors look like. In case he didn't, you will search in Google and just type dental probe. Yeah, the handle, the end of it is what we usually like using, and you just use it to tap at the top, the occlusal surface of the tooth gently, and not with force, because if you do with the force, and in case those guys have acute pulpitis, they are really going to hurt you. Yeah. So that's what we use. And then aspiration, it is, of course, the removal of all or a part of it from a body cavity. The area aspirated is usually a soft tissue, a bony lesion. Yeah, I think last time I was telling you guys about the, okay, not you guys, but I think another group. Yeah, the mandible, maxilla, sometimes they do develop lesions. For example, cystic lesions. Yeah. So how will you say this is a cystic lesion and this is abscess? Because it could as well be abscess. Yeah. Now I put here again a question. I think you guys are very proficient with cystic fluid. How will we know that this is a cystic fluid? Please, again in the chat room. Now this time I want everybody. I'm waiting 1 minute. 1 minute. How do we know that what we have aspirated is not blood, it's not pus, it's not any other thing other than cystic fluid? How will we know? Waiting. It will be clear. Somebody has said by illumination, I don't know how that is done. I'm not sure about that one. Where are the other people? Maraka thinks it is clear. Okay, I can see cystic fluid is not like cerebral spinal fluid, not at all. Cystic fluid has what is called straw-colored appearance. Yeah, it is okay. In my where I am seated, I have the color, but that color would be, maybe we could say like sometimes some passion fruits have that color. So it is a little bit we could closer to orange, but not really orange, something like that. So yeah, that's how it's clear like water. No, it's not clear like water at all. So yeah, you can do Google, and after this class you can search and look at how it actually looks. I'm sure Google definitely must be having how it looks like, but it is described as a straw colored, not clear. So when we do examination, we usually we do two things. There's what we call general examination, then we have local examination. So and the local examination is includes extraoral and intraoral examinations. When you do general examination, you are looking at the level of nourishment, the gait of the patient, the posture, their build. Look at things like blood pressure, their pulse, their temperature, their respiratory rates, their pallor, the cyanosis, edema, presence, absence, of course, presence, absence of pallor, presence, absence of cyanosis, ectorus, yeah, and possibly maybe also maybe do body mass index. Yeah, but maybe in a busy clinic, some of the things you like body mass index may not do, but there are things which are obvious. You can easily see cyanosis, you can easily see pallor in the eyes, you can see edema. Yeah, those ones really sometimes you can be able to see them. A person's gait, that one you can see how they're walking, yeah. Then after that, you proceed to do now the local examinations. You start by extra. You must always start with the extra oral examination, because when you do the extra oral examination, yeah, then you rule out that the problems are not from outside. And now let me proceed inside. So extra oral examination, you are going to look at the skin appearance, you are going to look at any lesions, you are going to look at the head, you are going to look at the face, you are going to look at the nose, you are going to look at the paranasal sinuses, you are going to look at the external ear, yeah, is there pus discharge and so on. You are going to look at the nasal mucosa, does it look normal, yes, no. You are going to look at the lips, cheeks, the lymph nodes, yeah. You guys know how to assess lymph nodes. You are going to look at the TMJ, you are going to look at the muscles of mastication and the salivary glands. Then in the skin, what are you looking for? You want to look for changes in appearance, yeah, such as rashes, sores, or ulcerations, and others, yeah. You are going to look at generalized pallor, okay. Is it present or absent? Yeah. So that can solve for you maybe instance of severe anemia, okay, or hypopituitarism, shock, yeah, syncope, and left heart failure. Yes. Then you want to look for yellowness of skin, yeah, which could solve for you maybe things like carotenemia. Then you want to check the texture, yeah, is it dry and inelastic? Yes. If so, then maybe there can be dehydration. If it's greasy, acromegaly, atrophied edge, yeah, or steroid medications. Other abnormalities such as petechial hemorrhages, yeah, eruptions, erosions, pigmentations on the skin. Yeah, I think you guys have already done dermatology, so you can easily be able to assess a normal skin from any abnormal skin. Yeah. So the head region, you need to evaluate it in terms of its appearance, its circumference, and so on. So the head has various shapes. The shapes can be described as mesocephalic, yeah, dolichocephalic, or brachycephalic. So mesocephalic is the average shape of head. Person usually possesses normal shaped dental arches. The dental arch is normal in these people. This is the average person. Most of you have this, yes? Then sometimes the second one, the dolichocephalic. Here, the head is long and narrow, and the patients usually have a narrow dental arch. So these are likely people who present issues of malocclusion, yeah, orthodontic problems, the ones which I was talking about. Not this one. Okay. Yeah. Brachycephalics, broad and short-shaped head. Persons use a broad dental arch. Broad dental arch. Then we said we also need to evaluate the facial forms. Also, again, 3 types. Mesoprospic is an average or normal facial form. Screen once again. It's quite annoying. Yeah, so these are the different facial forms. In any case, they help you to classify the nature of your patient. Yeah. So you want to look at what we call facial symmetry. I think this I talked to you last time. Because the face tends to be almost balanced right and left, yeah. So any abnormality you see, then it can already guide you, maybe there's something wrong. So Any asymmetry, any facial asymmetry, which is gross, you need to identify and record. Yeah, and this might arise from, let's say, congenital defects. There may be hemifacial hypertrophy or hypertrophy. There can be unilateral condylar ankylosis, hyperplasia, chronic abscesses, or presence of a cyst, space infections, facial swellings, facial fractures, and other tumors, and so on. There's what we call the facial profile. And the profile of the patient is determined by visualizing the patient from the side. Yeah, they can sit in front of you, look across. Yeah, then you can see them from the side of the ear. Let's say, yeah, from the side of the ear, from their side. And this helps in diagnosing gross deviations in the maxillomandibular relationship. Very key in orthodontics. And again, 3 types. Straight profile. How do you arrive at this? It's an imaginary line is drawn from the forehead, yeah, from the forehead to the upper lip. Forehead to upper lip. And another line from the upper lip to the anterior point of the chin, yeah. So those 2 lines intersect, and then they give you that profile. So in the straight profile, when you join those 2 lines from the forehead to upper lip to the chin, the line is almost straight. So that's a straight profile. Then there's the convex profile. The 2 imaginary lines form an angle with the concavity facing the tissues. Yes, concavity, you guys know concavity, yeah. So in this type of profile, the patient is likely going to have what we call prognatic maxilla or retrognatic mandible. So that means the maxilla is pushing a little bit forward, or the mandible is more inside. Yeah, that's just what those 2 terms mean. Then concave profile, the 2 imaginary lines form an angle with the convexity towards the tissues. Yeah, the convex part is towards the tissues. This type of profile is associated with a prognatic mandible. So here, the mandible again is pushing forward, and the maxilla is pushing backwards. Yeah. So, yeah. So now you guys know. So after that, then you could look at the nose, the paranasal sinuses, the external ear, and the nasal mucosa. Examine for any sinus pain, discharge, obstruction, if the person is having continuous sneezing, and if there's periorbital swelling or inflammation. So you need to observe, for example, is there apical abscess, yeah, of the upper tooth, and sometimes, if so, this may lead to acute sinusitis. Then there's things like nasal obstruction. Yeah, you guys have done ENT, so you know this better. Even epistaxis, yeah. So it sometimes can be seen things like cerebral hemorrhage. Now, after that, then we want to look at the lips. Yeah, coming more and more again home now. Lips. You want to look at the lip color, the texture, and you want to look and rule out any abnormalities, yeah, such as the angular or vertical fissures, sores, ulcers, nodules, plugs, scars, and any swellings. You want to notice the familion, yeah, the familion border, and the presence of what we call the fondesis granules. Fondesis granules, yeah. Yeah, familion is that basically that thick part of the lip. Yeah, you want to see, is it normal or it's not normal? Yes. Then you want to look at the cheeks. You want to check if there are any changes in pigmentation, is hyperkeratotic or any hyperpigmented patch. Again, you have done dermatology, you know this better, so you understand these concepts. Then you want to look at swellings. Is there any abnormal swelling in this cheek? Are there nodules, scars, or ulcers? When you are done with that, now you want to check the lymph nodes. Very key. They will inform you of any pathologies. You want to examine neck nodes, which is important, particularly in head and neck malignancies. You do a systemic approach. Yeah, you guys know how to examine those lymph nodes. So, of course, they are better palpated while standing at the back of the patient, yes, and the neck is slightly flexed to achieve relaxation of the muscles, particularly if you are going to do the deep nodes. So here is a distribution of these nodes. You can see posterior auricular, occipital, tonsillar, periauricular, parotid, submental, submandibular, yes, supraclavicular, deep cervical, posterior cervical, and so on and so on. So, yeah, you want to assess this. You have gotten your history. You want to see, are the lymph nodes enlarged? Yes and no. Are they tender? Yes and no. Are they fixed? Yes and no. Yeah. So you want to look at their location. So which of those? Yeah, you have seen the groupings, the number of nodes, the size. Are they very large? Are they small? Yeah. Are they hard? Are they normal? Yes. Yeah, I said, are they tender? Yes, no. Are they fixed? If you know when they're fixed, then we are dealing with a serious situation. Yeah. Yeah. So if they are not fixed, then they're mobile. Yeah. Can you move them? When you are done with assessing your lymph nodes, then you want to assess the temporomandibular joint. Yeah. So this helps you to determine deviation of jaw from the midline to the opening and closing of the jaws. And sometimes the causes of jaw deviation, traumatic injuries, infection of the jaw, fractures, muscular hypertrophy, dislocations. Yeah, the mandibles, the jaws can sometimes get dislocated. So then you want to assess the muscles of mastication. You want to palpate the origin of the masseter, okay, along the zygomatic arch, and you want to continue to palpate down the body of the mandible where the masseter is attached. Then parafunctions such as bruxism and cleansing will give rise to masseter pain, yeah, and also associated with the pain in the temporalis muscle. And then the temporalis is palpated in much the same manner like above. And also the lateral pterygoid muscle is sometimes painful on the contralateral side in patients with non-working side interferences. Yeah. So yeah, you want to assess the muscles of mastication. Are they tender? Because then maybe the person has got trismus, and sometimes the muscles are tender. Salivary glands, yes, salivary glands can get any problem, infections, tumors, and so on and so on, obstructions. Yeah, so major ones like the parotid gland, Yes. We want to check for any swelling over the region, note the extent, size, shape, and consistency of the gland. The position determination is vital, so as to rule out lymph node swellings, because you remember there are lymph nodes which are just in front of the parotid gland or even behind. So is it lymph node or is parotid gland? Sometimes there can be parotid abscess. In these cases, the skin over it is a little bit dermatous. You want to check the area for presence of any fistula. Yeah, chronic infection, abscess can form what? Fistula. You also want to assess the gland tract, the Stenson tract, and this one opens now inside the buccal mucosa, opposite the crown of maxillary second molar. The crown of maxillary second molar. And to see this, you want to retract the cheek for its proper examination. Submandibular gland, very important gland. History of the patient is to be noted, e.g. swelling with pain at the time of meals. Yeah, when people are excited, when they see food, I think even all of you must have experienced this. You see some sweet food, you see saliva ejecting out of your mouth, it is coming from this gland. Yeah, so when it is obstructed with calculi, so you become excited, you want to delve into eating some sweetening, then the saliva is ejected, but it's blocked. Then the person develops a swelling and pain just at around times of meals. Yeah, so inspection over the area of the gland to be done to check the overlying skin color and the distension of the mucosa and the orifice of the Wharton's duct. That's where the discharge is from. So you do by manual palpation in the open mouth. Your finger, one hand is placed on the floor of the mouth and pressed as far as possible. The finger of the other hand is placed on the exterior, outside, and at the inferior margin of the mandible. Yeah? So these fingers are pushed upwards and palpation is achieved. If the gland or duct is infected, slight pressure over the gland will exudate pus. Yeah, the orifice. So examination of lips and labial mucosa. The clinical features of normal lips and the labial mucosa are: 1, reddish color over the area, folds and sulci over the surface of lips, absence of any plaque or patchy area, and absence of any erosive areas. So a normal lip, you are very familiar with the normal lips. Abnormalities like competency, color, texture, fissuring, shape, presence of any lump or hard tissue. Competence means if the person is able to bring together the lips. When people have like facial palsy, they develop incompetence. Yeah, so I think that one is very clear. Some of the abnormalities of the lips, lip pits and commissural pits. These are congenital defects of lip and labial mucosa that result in unilateral or bilateral depressive pit that may occur on the lip region or on the commissures or angles of the commissures at the angles of the mouth. Then there can be cleft lip. Yeah, cleft lip. I think Martin must have taught you about cleft lips. Some of you have seen cleft lips. These are some of the most common developmental malformations of the lips. So this is how a cleft lip looks like. This is a unilateral cleft lip. Yeah, you can see it's on the left side. Yeah, sometimes it can be bilateral. You can find here is a cleft and also another cleft on this side. So it can be unilateral. Now this is a complete unilateral cleft involving the alveolar bone. Yeah, yeah. But it could sometimes also stop just somewhere here without involving the premaxilla actually. This yes, alveolar bone and the premaxilla. It is all involved. Yeah, sometimes you find the unilateral or bilateral, they can be complete, yeah, or incomplete, and so on. And so that today is not a lecture for that. So that I'm sure the guys of plastic surgery can teach you more about that when you are learning specifically about cleft lips. But today, our interest is when you see one, then you know that this is what? A cleft lip. Then you know that, for example, this one is really a complete unilateral cleft lip of the left side, yeah, involving the premaxilla and the alveolar bone. Yeah. So some of the things you will find in the lips are like angular cheilitis, which is inflammatory lesion at the labial consa. I would say this is the corner of the mouth, and often occurs bilateral. Yeah. So so you will see deep cracks or splits. Yeah. So sometimes when people have severe fever, they do develop these kind of things. Then angioedema. This kind of edema, there are people who are allergic to certain foods. You find maybe they are allergic to nuts and stuff like that, or even fish. Yeah, they put it there and then they're going to develop such things. I think you have ever seen this kind of reactions. Then when you are done with the lips, now you want to look at the buccal mucosa. That means now you are inside the mouth, yes? So is the internal lining of the cheek region. The mucous membrane often varies considerably in thickness from one area to another, but it is generally thick and pink like the labial mucosa, which it is continuous. Any abnormalities in the buccal mucosa will be things like white lesions of oral cavity, such as hyperkeratosis, leukoplakia, actinic keratosis, candidosis, or what you can call candidiasis, yes? Chewers mucosa, white sponge nevus, lichen planus, and so on and so on. Yeah, if you have already done dermatology, these are the ones you know them very well. You know what lichen planus is, you know what is white sponge nevus is, you know what leukoplakia is, you know what hyperkeratosis is, you know those ones very well. So the ones you already know from dermatology, you just transfer that knowledge here, then you will know what we are talking about. Then there can be red lesions of oral cavity, like hemangiomas. Yes, even on the skin, you see hemangiomas. So the same way, it will all look more purple when it's the mafia. Yeah, hemangiomas, varices, erythroplakia, ecchymosis. I think we talked about ecchymosis last time, yes? You saw some pictures of ecchymosis. Yeah, so yeah, same, you already know this. Yeah. Then ulcerative lesions of oral cavity, trauma after stomatitis, parenchyma, Behçet's syndrome. Yeah. Yeah, after stomatitis, please, you need to take interest in this one. Yeah, after lesions they tend to be a little bit common. They can be minor or major. So please, because the person can come to you, says, oh, I had eruptions in my mouth and now they've ruptured. Now I have wounds. Yeah, so then you know those things come on and on. You just palliative care, that's what they will say. Just to help them, they will always go once you do good care. Yeah, good oral care, some little bit of analgesics and so on, it will go by itself. So you also need to examine the floor of the mouth for important things may be hiding there. So floor of the mouth is a narrow hoso-septic depression line between the base of the tongue and the alveolar processes of the mandible. The midline has what we call the lingual frenulum, and this is connecting the inferior surface of the tongue with the floor of the mouth. So clinical and normal floor of the mouth presents cyanide-pink surface, presence of normal lingual frenulum attachments, absence of any patchy or ulcerated lesions. So abnormalities, you may find things like the mandibular tori. This is a physiological enlargement of alveolar processes on the lingual surface that can be seen while examining the floor of the mouth. Mandibular tori. Sometimes you can mistake them for, maybe you can think it's an abscess, or you may think it is a maybe a malignance or what, but the mucosa on top of them is normal. So there's a ranula, which you can also see in the floor of the mouth. This is a traumatic swelling that occurs on the floor of the mouth as a result of calculi in the duct of the salivary gland or obstruction of minor salivary glands on the surface. So what we are seeing here at the mandibular tori, you can see where they're coming from. Yeah, from the alveolar process. So when the mucosa is usually normal, unless if something has traumatized it. And when you palpate, when you examine, it's really firm, it's a bone firm. Yeah. Yeah. So yeah, because maybe it is stretching so much the mucosa, when eating food, it can be traumatized. So it is always easy to remove them. Yeah. You can just debulk them and you close the mucosa and it will be normal. They rarely grow back. This is a ranula. This is the tongue. You can see the tongue. This is the lower arch. Below the tongue here, this purplish stuff you see here, this is really a very big ranula. Yeah, it's a very big ranula. The tongue. You see, the tongue is the one which can light a big fire and consume the whole world. That's what people say. So we need to be careful and examine it properly. So the dorsum of a healthy tongue is covered by a mucous membrane, the presence of thousands of papillae projecting onto the surface. Yeah. And the three major types of papillae present on the surface. We have the filiform papillae, the fungiform, and the circumvallate papillae. Yeah, so no details now for this. You start the data. A normal tongue presents the following characteristics: moist reddish mucosa of the dorsal surface, roughness over the dorsal surface, indicating the presence of papilla or papillae and absence of any plate or ulcers. This is how, this is almost close to a normal tongue. Yeah, you can see how nice it looks. Very nice. The normal the structures of the papillae. You can see them here. Yeah, it's very clean, very normal, no ulcers. Yeah, it really looks very normal. So, the dorsal and lateral surfaces of the tongue are best examined by asking the patient to open his mouth or her mouth wide and the tongue thrust forward. You ask them, in Nyakore, we usually say, Yashama, Yashama. And then after, then you say, the tongue, I think, or something. We push it out, yeah? So then they can push it out. And then you can hold it with gauze, and then you can be able to manipulate it the way you want. Yeah, because if you hold it with your examination gloves, it's usually slippery. It will just pull. You know, the tongue is notorious. It likes going back inside. So it will just pull away. But if you hold it with gauze, gauze is rough, gauze will hold it tight so it will not slide away. Yeah. So then you can be able to examine it, the side, and the under part, you can just tell them to raise up the tongue to the roof of their mouth. That's very easy. Yeah. So some abnormalities which you may want to be aware of are things like aglossia, which is absence of a tongue, which can actually happen. Microglossia is a small-sized tongue. Macroglossia, large-sized tongue. Yeah, sometimes you really find the tongue is filling the whole mouth. You wonder what next, yeah? Then ankylossia, yes, which is also common known as the tongue tie. Yeah, these mothers are always going to bring their babies to you. My baby has a tongue tie, yeah? So it is always bothering them, and so you need to be aware of this. Then is sprue, a common condition seen in malabsorption syndrome, where the tongue becomes severely ulcerated and inflamed with a painful burning sensation. Yeah, last time we talked about burning sensation. Yeah, malnutrition, malabsorption. So this is ankylossia. I just want to emphasize, but I can assure you, you are going to see hundreds, and particularly if you practice here in Uganda or in Africa, mothers are going to disturb you for this. They will tell you, see, our baby cannot speak because of this fibrous, attachment. Yeah, this is the frenum, but in ankylossia, it attaches to the tip of the tongue. You can see how it depressed the tongue here, and here at the alveolar ridge, yes? So it really shortens the tongue. So it's just a matter of cutting here and you release it. It's very simple, but you need to make the diagnosis properly. Yeah. Sometimes the tongue is really normal, but you find that the mothers are still complaining. Yeah. So things like conditions like iron deficiency anemia, the tongue presents as depapillated, yeah, with erosive lesions. Then there's fissile tongue, geographic tongue. I talked to you about geographic tongue last time, and I hope you guys went and search for it. Of course, there's the fissile tongue, there's ulcers, there's squamous cell carcinoma. Wow, that one is fairly common. Then, yeah, then there's also median rhomboid glossitis. I've just given you here two examples of this. The fissile tongue, this is how it looks. You can see the fissures. Yeah, it's a fissure all over like a tire. Then this is the geographic, the famous geographic tongue, which can present also with the burning sensation. So you see these eroded parts here, yeah, all over, yeah. Yeah, this is, you see like maps. So this is what a geographic tag is. Then palette, you know, the palette has the hard and soft palette. The hard palette has an incisive papilla, a soft tissue portion overlying the incisive canal, a median palate and raphe, yes, which can be distinguished by a shallow depression or a low ridge extending to the soft palate, and palatine rugae, which are dense ridges of mucosa present on anterior hard palate. Then the soft palate has the ovula, of course. Yeah. Sometimes this ovula, by the way, can cleft. Yeah, sometimes you can find that it has a cleft. But yeah, sometimes it has its own clefting when it is a problem. So this is how a palate will look like. You can see the midline fibrous tissues and those lines which are always running here, particularly on the hard part, anterior part. This one even you can examine your own. So yeah. So, and the hard, which ends somewhere here, and then the soft and the ovula is obviously somewhere hiding under here. Okay, in the palate, there can be some defects, like the cleft palate, which results in incomplete fusion of the two lateral processes, creating a gap in the palate. So the cleft palate may be complete, yeah. This can involve the hard and soft palate, or incomplete, involving on the hard palate or on the soft palate. I told you that, for example, the ovula sometimes you find is having a cleft, but even doesn't extend beyond that, yeah, sometimes. So this is a young baby who has all sorts of clefts. You can see as here bilateral cleft of the lip, and also the cleft of the palate. This is really a massive cleft, very, very massive cleft. Must be felt to thrive, and you will end up dying out of malnutrition. Yeah. Yeah, my internet is a little bit unstable. I just pray that it doesn't shut down again. So on the palate, sometimes there can be other abnormalities other than the clefts, like a torus palatinus. This is a slow growing. It's like almost the other mandibular torus, but this is now the palate. Then there can be smoker's palate, a common condition where multiple patch seen over the upper palate as a result of inflammation of minor salivary glands and the hyperkeratosis. Yeah. So this is the torus palatinus. You can see it can be sometimes very small. Yeah, sometimes it's just small, but this is a big one. Yeah, but you got to differentiate it from other causes. Sometimes we have seen here, you may think it is a, you need to examine if it is really bony hard, likely, but sometimes maybe there can be a cyst from inside there, which could as well also push this. Or sometimes it can be an abscess, sometimes if it is a little bit rubbery, yeah, rubbery, then it can easily be things like lipomas, which can come from somewhere here and extend in there. Yeah, so you need to examine it properly. So now, when there are swellings, how do we inspect or examine swellings? You need to check the site of the swelling. Where is it? Is it on the cheek? Is it in the floor of the mouth? Is it on the palate? Yeah. Is it in the vestibule? Where is it? Is it on the lip? Yeah. Shape of the swelling, how does it look like? Size of the swelling, is it small? Is it large? The surface mucosa, is it normal or is it ulcerated? Or it is nodular, yeah, indurated and so on. The edges of the swelling, is it smooth? Is it rugged? The number of swellings, is it isolated? Is multiple? Does it move when you swallow? Does it move when you protrude the tongue? So all this will give you an idea what you are looking for. So of course, we have not really dwelt so much on the different pathologies in the head and neck, but this should be able to give you an idea really briefly what you are dealing with. In case of ulcers, which will always be there, they can be traumatic, they may be due to tumor malignancy, yeah? So you need to look at the shape and size. So different diseases produce a variety of ulcers. For example, syphilitic ulcers, yes, circular or semilunar carcinomatous ulcers are irregular in shape, yeah? And of course, carcinomatous ulcers bleed very easily, so that can also help you to know that we are dealing with something which is really notorious. Traumatic ulcers, you can know there was history of trauma. Yeah, there was history of trauma. So, and maybe it is a tear or something pierced it or something cut it. Yeah, that one is very easy. Then you want to, if there are ulcers, you want to look at the numbers. Is it isolated? Are there many? Yeah. Ulcers of neoplastic origin, tuberculous ulcers are solitary. They are solitary. While others are numerous number. For example, recurrent aphthous ulcers. I told you that you are going to see many patients with aphthous ulcers. Yeah. Those aphthous ulcers are always precipitated by some factors such as stress. Then they just erupt. Just instantly, you just see the patient coming back. The ulcers are back. So if you see that there are multiple scattered, then it's likely. And also sudden onset, then you should just start thinking of aphthous what? Ulcers, not really maybe a malignancy, or unless if it was due to trauma. Yeah. The position of the ulcer over the face or in the oral cavity gives clue about the diagnosis. Ulcers of squamous cell carcinoma reside mostly in the middle third of the face. Position of traumatic ulcers in dental wearers. You know where the dentures are going to be. They will be on the dental arches. So, and also maybe they can traumatize the tongue if they are unstable, yeah, or the palate if they are unstable, yeah. So you look at the edges of the ulcer. Yeah, I've not dwelt so much into the edges. I think you know how to particularly detect malignant ulcers. Yeah, if the ulceration is due to a malignancy, things like induration and things like, you know, maybe the surface necrosis and so on and so on. The different features. Yeah, I think now you can use your job pathology and the maybe knowledge elsewhere to be able to identify this. So, okay, good. I had to move quite fast because I can see the students have also been falling as fast as I was falling. Thank God we still have 27 in class. Yeah. Let me check. There's a post in the chat room. Yes, from JK. JK says, why have tongue ties been even found to be particularly common in Africa? Now, tongue ties. Okay, if I will definitely need to look out this. I'm not sure if they are really more common in Africans. I'm 100% not sure. I know there was some colleague who did a study about again disturbed, but yeah, I was saying that I don't have a specific answer for that because I'm really not 100% sure whether we have more tongue ties in Africa than elsewhere. So I need to do a quick review of the literature. So next week on Monday, I should be able to have a better idea to give an answer to that. Yeah, I don't want to confirm something which I'm not 100% sure. Yeah, so yeah. Unless if there are other questions, this internet has really frustrated me. I'm quite happy with those of you who have been able to bear with me and yeah, who have been able to sustain up to this moment, despite the fact that
Doctor, we're not hearing you.
On and off the network. Yeah, it's quite frustrating. Oh, I don't know why, but I've unmuted.
No, we are hearing you, Doctor. It's okay.
Hear me?
Network.
Hello, Paddy? Okay, Miro. Yeah. Okay, Miro,
Yeah.
you can ask your question.
Yeah.
Yes, I can see Miro's hand up. You ask your question before my internet again disappears.
Doctor, so my question is, if a patient has, for example, a tumor coming
that's
from...
Nathan. Yes, okay, Nathan, your network is up. Yes.
I don't know if
Hello,
I can be
Nathan.
heard. Doctor, can I be heard?
Yes, we are hearing you.
Okay, so my question is, if you have a patient who has, for example, a tumor coming, is it a case handled by the oncology team, or those cases are still under dental? So is there a subsection for dental?
Yes, Nathan, yes.
Oncology?
Yeah. In your curriculum, well, you see, this is the first time ever for us to design this course. So we just wanted a course which was able to interest you guys to appreciate dental and oral health. I think we have succeeded in that, and the feedback from people like to improve it. Yes, Paddy, I can see your hand is up. Hello, Paddy.
Yes, thank you, Doctor. I don't know whether I had typed my question in the chat box, then I had network issues. So I have two questions.
It disappeared. Yes.
Okay. My two questions are, I've seen people who can have very long tongues that they can touch their nose. I've tried it and I've failed. I don't know why that happens. Then my second question is something about locked jaw. Is it from a dislocation or what way a person cannot? Actually, it's from eating hard things like hard meat for a long time, hard food. And when you chew, then you cannot, it reaches a point where you cannot open your mouth up to a certain degree with your teeth, and you can. I don't know if you have come across that.
Paddy, no, Paddy, my network again disappeared.
Okay. Doctor.
Repeat the
Still
question
not.
for me.
Okay.
Yes, Paddy.
My question is, how comes there are some people who can touch with their tongue on their nose? Are they people with anomalies that their tongues are long and they can touch their nose with the tongue? I've tried it and I've failed. Then my second.
Yes. The second one?
Yes. The second one is about locked jaw. Is it
Yes.
from a dislocation or what? Where mainly they associated with eating hard things, maybe those gundi maize, which is hard and has been fried, and you start chewing, then it reaches a point and you hear like at the joint TMJ, it is like kata kata bursting, and you cannot open your mouth.
And then you cannot close, you cannot open.
Yeah.
Okay, the first one, I think the first one has a genetic basis. Different people have different phenotypes, which are expressed from their genes. So there can be slight genetic variations. So there are people who can roll their tongues. Personally, I cannot roll my tongue. And there are people who have slightly longer tongues, which are actually normal. Yeah, that one is just, I think it's mainly genetic. You cannot really modify your own tongue. There are certain body parts which you cannot easily modify. So those ones are just phenotypes, expressions out of the genes. So the second one is, let's say, getting basically, I think when you strain the TMJ, there are sometimes the articulation can be dislocated. I think you are going to see a number of those cases in real life. A person come in, then they trace, they can no longer open, they can no longer close because the articulation is dislocated out of the socket. Yeah, so that is usually what happens. Yeah. So is there any other question?
The treatment for
Were
locked
you
jaw.
able to hear the answer, Patty?
Yes, doctor.
Okay, if it is ankylosis, then usually physio. If it is still new, we can use the physio. But if it is old and heavily fibrosed and then ossified, no, that needs surgery. But if it is due to dislocation, then we just have to reduce it. By manually, you reduce it. But now we didn't teach you how to do it. But next time when it happens, you have a case, you just bring them, we can demonstrate for you how to do it. Or you can check a YouTube video how to reduce dislocated jaw. Yeah, it is some skill which you need to know because next time you are the only one and you don't need to delay those patients, because when you delay, fibrosis is going to set in and to return be a little bit more complex. Yeah. Any other question? Any other question? I don't see any question in the chat room. Where are the hands? Let me check. I don't see any hand. Is there any other hand or any question? Any question you can post in the chat room. The network again In the, yes, I'm not seeing any hands up. Okay, let me check it down. Okay. There are no hands up, and I'm not seeing any questions in the chat room. So, okay. Now, since you guys have run out of questions, I would like to thank you so much for joining me in this class. Let's meet again on Monday, and then we'll class because we are just going to discuss why do we remove the teeth. In case we are to remove, what do we need to do, and